Today, we're going to talk about a typical presentation of disease in older adults. This presentation was created by Dr. Donald Juravich, a professor of geriatrics at the University of North Dakota. We want to talk about atypical presentations, particularly as it relates to COVID. The problem is within older adults, there's such an exceptionally high mortality, particularly amongst those who are 80 years and older. The presentation of not only COVID, but also other types of infection in older adults is often very atypical. By the time we catch it, they progress so far into the disease that it's unfortunately irreversible. That's based upon the fact that age changes the way our body reacts to infections and other acute conditions, such as a heart attack, but it doesn't always present classically in the older adult. One of these changes is that older adults don't always mount a fever when they are infected. A fever may not occur with infections. In fact, most of the time older adults do not have a fever with their infection. Importantly, if there is a change in temperature from their baseline, a 2-degree difference is considered important and may by definition be a fever. If somebody has a baseline temperature of 97, a temperature recording of 99 could then represent a fever in that particular patient. If there's a drop in the temperature, that could also represent an infection. Sometimes it's associated with sepsis. If somebody normally has a 98.6 degree Fahrenheit temperature, if it goes down to 96 or 97, that could very well be another indication of infection in the older adult. The bottom line is, really know the patient, know the resident, know what their basal temperature is, and know if there's a 2-degree difference or a drop in that temperature. Act as if it's an infection and do the workup accordingly. For today's first polling question, we'd like to know, in older adults with infections, what is considered a significant temperature change that may indicate fever or sepsis? A. A rise of 1 degree Fahrenheit from baseline. B. A rise or drop of 2 degrees Fahrenheit from baseline. C. Only a drop below 98.6 degrees Fahrenheit. D. No change is significant. Fever is always absent. The correct answer is B. A rise or drop of 2 degrees Fahrenheit from baseline. What about other vital signs? In this particular chart, this is called the curve 65. The curve stands for those different abbreviations of confusion, respiratory rate, and so forth. As you have more and more of these changes in vital signs, such as an increase in respiratory rate or a drop in blood pressure, the more critical the patient becomes and the more likely they need hospitalization. If you have 2 or more of these findings, the older adult needs to be routed to the hospital as quickly as possible for medical intervention. If you notice somebody with a respiratory rate of 30 breaths per minute in an older adult, that could be near ventilatory failure. The ventilatory drive is not that strong in older adults, and so when they're breathing rapidly, they're in big trouble. Subtle changes in respiratory rate, for example, going from 18 to 22 breaths per minute, should be noted and acted upon accordingly, such as getting a pulse oximetry and doing other evaluations. At that moment, that includes blood pressure and temperature monitoring. With COVID, there was a study that compared nursing home patients in the green bars versus community-dwelling older adults in the orange bars. On the left side, the cough, fever, and dyspnea is fairly similar in both populations, but there's a little bit of less of a cough in long-term care residents. There are 3 elements of presenting symptoms that older adults and long-term care are more likely to have. Loss of appetite is represented by anorexia. They're much more likely to have delirium or an acute confusional state, and they also have falls. Although there may not be much difference, those are the 3 big ones for what we call atypical manifestations of COVID in the older adult population in the nursing home. Let's focus on delirium. Here we see a representation of the painting called Scream by Edward Munch. It very vividly tells us what we see in the clinical setting for delirium, which is confusion, poor attention span, and disorientation. This chart is the confusion assessment method, or the CAM score for delirium. You have to have two of the elements: an acute change in mental status with some fluctuations, and then into attentiveness. The inattention is a very important feature. These are the people that if you ask them to count backwards from 100, will start with 99, and then they start skipping to 88, and maybe they go to 60, and then they just lose their trail of thinking entirely. You have to have these two features, and then additionally, either disorganized thinking or an altered level of consciousness, which may be hypoactivity or hyperactivity. Most cases of delirium are not the hyperactive version. These aren't the people that are bouncing off the walls or bouncing off the bed. More likely, the older adult is to have hypoactive delirium, and these are people that take to the bed. They don't want to be bothered. They are patients that you think are just resting, and in fact, they may have a hypoactive delirium. For the second polling question, which of the following is the most common type of delirium observed in older adults during infections like COVID-19? A. Hyperactive delirium, agitated, bouncing off walls. B. Hypoactive delirium, withdrawn, lethargic, taking to bed. C. Mixed delirium, alternating between hyper and hypoactive. D. No delirium occurs in older adults. The correct answer is B. Hypoactive delirium, withdrawn, lethargic, taking to bed. Turning towards COVID, in particular, the symptoms we know and are familiar with are fever, chills, cough, shortness of breath, or difficulty breathing. A lot of times, very profound fatigue, even in younger people. You may have muscle aches, headache, loss of taste, or smell that occurs in about 40% of the patients. People with Alzheimer's dementia lose their sense of smell, so they're not going to tell you any differently if they have COVID. Also, sore throat, an increase in runny nose, nausea or vomiting, and diarrhea. These are all various symptoms that we need to be aware of and their new onset. If a symptom has been occurring for years, that won't count towards your symptom checklist. In the older adult, it's so important to recognize that atypical COVID can be represented by change in mental status, delirium, or falls. Also, loss of appetite is represented by this older adult pushing her plate away. Anorexia is also an important atypical manifestation of COVID that we need to keep in mind. If anybody has those types of symptoms, they should be evaluated for COVID immediately. Today, we're exploring a case study on an atypical COVID-19 presentation in geriatrics, featuring Mrs. Eleanor Thompson, an 85-year-old widow in a long-term care facility for 3 years due to mild dementia and osteoarthritis-related mobility issues. She's frail but independent in ADLs, with a baseline temperature of 97.2 degrees Fahrenheit, good appetite, finishing approximately 80% of meals, active in group activities, and ambulates using a walker with no recent falls. Comorbidities include hypertension, type 2 diabetes, and CKD stage 3. No recent travel or known exposures, but the facility has seen sporadic cases in 2025. Over the past 48 hours, staff noted subtle changes: increased withdrawal, spending days in bed, just resting, refused 2 meals, saying, "I'm not hungry," an unwitnessed bathroom fall with no pain but disorientation, repeatedly asking about her daughter, vague tummy ache without localization, no classic symptoms like cough or fever. Family, contacted by phone, noted no prior changes and expressed concern over her lethargy. Initial assessment by the geriatric NP. Her vitals showed a temperature drop to 95.5 degrees Fahrenheit, 1.7 degrees Fahrenheit below baseline, nearing 2 degrees Fahrenheit sepsis threshold. BP 102/68, down from 130/80. Respiratory rate 24, up from 16 to 18. Heart rate 92. Oxygen sat 94% on room air. CAM positive for delirium. Acute onset, inattention, can't spell world backward or follow commands. Hypoactive features. MMSE dropped from 22/30 to 15/30. Physical exam. Alert but hypoactive. No neurodeficits. Clear lungs. Soft abdomen with diffuse tenderness. No edema or rash. Elevated frailty index. Diagnostic workup. Rapid COVID antigen test was negative, false negative suspected. PCR positive for SARS-CoV-2, Omicron subvariant per 2025 circulation. Labs. Mild leukopenia, white blood count, or WBC, 4.2 times 10 to the 9th per liter. Elevated CRP, 45 milligrams per liter. Normal procalcitonin, rules out bacterial. UA is negative for UTI. Chest X-ray, subtle bilateral ground glass opacities, early pneumonitis. Management and outcome. She was transferred to the hospital per CURB 65, score 2, confusion and high respiratory rate. Received supportive care. 2 liters of oxygen per nasal cannula. IV fluids for dehydration, low-dose dexamethasone, non-pharmacologic delirium management, reorientation, family video calls, quiet environment. Avoided haloperidol due to hypoactive risks. By day 3, temperature normalized, appetite returned, delirium resolved, CAM negative. Discharge day 5 with renal-adjusted oral Paxlovid and monitoring. 30-day follow-up. Full recovery, avoiding prolonged hospitalization. Important points here include atypical symptoms, delirium in 35%, anorexia in roughly 51%, falls in about 32%, are red flags in older adults, per reviews, prompted early testing despite negative antigen. Vital subtleties like 1.7 degrees Fahrenheit drop signal decompensation. 2 degrees Fahrenheit baseline deviation defines geriatric fever. Hypoactive delirium, 75% in geriatrics, 53% in infected elders. Risks being missed as aging, CAM, and baselines were key. Knowing norms via handoffs reduced mortality risk, up 30% if unrecognized. In 2025, with variants, integrate frailty screening and teams for silent infections, plus updated vaccinations. Sometimes people just garble about stomach aches, abdominal issues, or discomfort that's very nonspecific. Nobody's going to point with their finger and say I've got abdominal pain there. It's very diffuse. That could be another sign of COVID. It's also another sign that you may see in bacterial pneumonia or influenza. Abdominal complaints could very well be associated with COVID. In summary, it's important to realize that infections present differently in older adults, particularly in long-term care where they're frail. It's important to know what the baseline physical and behavioral characteristics of the patient are. If they run a basal temperature of 97 degrees, that's important because if it goes up to 99, that could represent a fever. Always let new staff or somebody who hasn't taken care of the resident know what those baseline features are. Somewhere in the chart there should be documentation what the basal temperature typically is, and also what their baseline behavior may be. Remember that a 2-degree change in temperature could represent a fever, as well as a drop in temperature. Those are both important, and in terms of confusional states, always be on the alert for the patient that takes to bed or doesn't want to be bothered. 75% of those deliriums are represented by hypoactive delirium. The atypical manifestations of infections in older adults, a lot of times they have confusion. Studies of half of the long-term care patients with COVID manifested confusion in the community setting. It was 1 out of 3 patients, so it's very frequent, and they also may have falls, as well as loss of appetite. All those should prompt further evaluation for COVID infection. Thank you for your attention. We hope you can continue with these short snippets of geriatric care and dealing with the older adult as we move forward.